Hi, everyone. I will be going through my poster that I've been working on throughout the Margolis internship this summer, and the title is Limitations of Current HCTP Donor Eligibility Guidance, Analyzing the Impact on a Large Public Cord Blood Bank. So some background on this topic of why do we bank umbilical cord blood in the first place? It contains hematopoietic progenitor cells, which are used to treat different blood disorders in certain cancers, for example, leukemia. And cord blood does not require as precise tissue matching in terms of donor and recipient matching compared with other stem cell transplant methods. Often it is the best option for racial and ethnic minorities, partly due to that reason, because the donor pools of blood donation are predominantly skewed towards the white population, and the fact that cord blood is less precise in matching requirements makes it a more accessible option. However, there are some problems with the current FDA regulations surrounding eligibility of donors. So there's outdated guidelines for human cell tissues and cellular tissue-based products, or HCTPs, which is the broader window of FDA regulation that cord blood falls under. There are often inconsistent regulations for whole blood, which is just like regular blood transfusions, versus HCTP or cord blood. And particularly of interest to us is the restrictive Zika virus guidance. There's a lower supply of cord blood units for certain racial and ethnic populations as well, and that limits the accessibility of the units. So with that said, our objectives this summer were to analyze the impact of Zika virus donor screening recommendations on the licensing status of banked CBUs. And by licensing status, what I mean is the eligibility for a biologics licensing application, which is the method that cord blood banks take to be licensed through the FDA and get reimbursed by HRSA for the cord blood units, and then to propose updated FDA policy recommendations. Desired outcomes are to first update HCTP recommendations, then increase the number of eligible donors, have a larger quantity of licensed cord blood units in the cord blood bank supply, and then ultimately down the line, improve access to stem cell transplants. So getting into some of our methods and results. First, we started off with a retrospective analysis of the Duke Carolina's cord blood bank data, which started with banking from January 2016 up through this past May 2022. And the Ccbb is a large public cord blood bank that serves a variety of regions in the Southeast. So in this table, I have organized the CBU status organized by banked and infused. So infused means the unit was actually shipped out from the blood bank and given to a patient. So we started off with a total of 8,877 units that were banked, and of those 236 actually infused. So that was only about 2.7%. Notably, the proportion of banked unlicensed units that were infused of 2% is lower than that of banked licensed units at 2.7%, which suggests a sort of bias towards the licensed units versus the investigational new drug or IND unlicensed units. The Ccbb data also shows that 689 or 7.8% of total cord blood units were unlicensed due to the mother's travel-related Zika virus risk. So that would have been identified on a maternal health history questionnaire and made those units ineligible. Of those 689 units, 7 were actually used in transplants, so they were infused. And then of those, 0 documented cases of Zika were reported. So that's definitely interesting to note. We also had data that showed a decline in the number of units with Zika identified risk from 2020 to 2021, and it was a pretty sharp decline as well, which is notable, but less so of an interest just to the fact that it's partly probably due to COVID and less travel. So we're very curious to see how that trend persists or changes throughout the entirety of 2022 as well. Next, we did some donor eligibility analysis by looking qualitatively at some of the FDA guidance for whole blood versus the blood components of, so that's HCTPs, and of interest to us mainly was cord blood. So we looked at Zika in comparison to HIV or human immunodeficiency virus, or VCJD, which is a neurodegenerative disease that's also of interest to the FDA in terms of relevant communicable diseases. So for HIV, the whole blood was updated in 2020, the guidance to reduce the donor deferral period to 3 months for MSM risk. So the donor deferral period means that if a prospective donor has an identified risk, then they can be deferred for 3 months before being able to have that eligibility versus alternatively, such as either a 6-month or eternal deferral period. So that was notable, and to increase the blood supply in 2020. For BCJD, guidance was updated in 2022 to remove travel restrictions for blood donation, but both of these also were not updated for cord blood yet. For Zika, similarly, the whole blood was updated in 2021 to declare Zika a no longer relevant transfusion transmitted infection. So the FDA recognizes that Zika is a lot lower risk now and a lot lower prevalence than it previously was. However, the cord blood guidance is still in that 2018 restrictive phase of limiting the mother's travel requirements for donation. Next, looking at the Ccbb unit distribution by race. So first, this is just an overall distribution of those banked and infused units, which are pretty similar to one another, with the largest proportion being of Caucasian donors. Also, just as a note, these racial and ethnic abbreviations are in accordance with what HRSA banks, because HRSA has set quotas for the blood banks to collect a certain percentage of each race and ethnicity for purposes of reimbursement. So those are just the terms and analysis that we were able to conduct with that data. So there's evidently a lot lower of a supply of blood bank units for the racial and ethnic minority populations. And part of HRSA's goal is to increase that percentage, and that's why they keep track of it in this way. Then I did a further analysis into the investigational new drug Zika units. So those are units that were not licensed due to the Zika risk, and found that actually 22.8% of those units came from Hispanic donors, which is really notable because only 16% of the overall units that were both licensed and unlicensed in total came from Hispanic donors. So perhaps if the Zika virus unit or Zika virus guidance from the FDA was loosened a bit and updated to reflect the whole blood guidelines and the current public health situation, perhaps more units would be accessible to racial and ethnic minorities. So some of our conclusions are that outdated FDA guidance limits the number of eligible cord blood units and then thereby threatens cord blood bank sustainability. Additionally, the investigational drug unit status may deter selection or infusion to patients. So that's something to keep note of as well, because we've looked at several studies that actually note that infusion with an unlicensed unit has similar or analogous downstream health implications and same survival outcomes compared with licensed units. And updates may advance health equity. So that includes providing more options for stem cell transplants for racial and ethnic minority patients. And I'd also just like to thank my mentor, Dr. Shaz, who's been such an amazing resource and collaborator throughout this project, as well as Dr. Kurtzberg, who's been a collaborator, and Jose Hernandez, who has helped a lot with actually pulling and analyzing the data. But yeah, that was my presentation, and please feel free to email me or reach out with any questions.